Ladies and gentlemen, it is with outstanding pleasure that I welcome you to the Fall 2025 Medicaid Fair. And now, without further ado, introducing Gainwell Technologies Account General Manager and Technical Director, Talisha Hodge Thompson, and the wonderful, fantastic Provider Relations team. Give it up, everybody. Give it up. All right, come on. Energy, 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 energy. That's right.
Yes. Y'all know how we do. Y'all know how we do. We got to make sure everybody's woke. They're ready for today because we have a lot of great information for each of you today. So what are we going to do? We're going to start out by saying good morning to everybody. We're going to call out your group, and you're going to say good morning back. So starting with Gainwell Technologies, good morning. Good morning. Department of Community Health, good morning. DCH, good morning. Woo! All right. Providers, good morning. CMOs, good morning. Yeah. And all the vendors in the back, good morning to each of you. We are super excited about being here today. We are super excited about being here today. I can't say that enough. So before we get started, though, I want a little interaction with you. What I want to know is, what is it that you expect to gain from the sessions today? I'm going to walk around the room, pick a couple people. You just tell me what you're expecting to get out of the sessions today. What are you expecting out of the sessions today?
I would like to meet new people.
Awesome. Thank you. Absolutely. What would you like to get out of the session today? What would you like to get out of the session today?
I'm still processing.
You still processing? All right, we're going to go behind you. What would you like to get out of the session today?
How to reduce denials.
All right. How to reduce denials. Yes.
We got one more.
All right, go ahead. Tell what you got.
Answers.
All right. Making sure we get every section. What would you like to get out of the session today? As soon as he comes back. My guy, Brandon. Knowledge. That's what I'm talking about. Thank you, everybody, for sharing. We really appreciate that. And I love the energy that we have in this room. We got to keep that going for the rest of the day. Now, without further ado, we're going to introduce to you your fabulous, amazing provider rep team. But before we do that, we're going to allow Anita Hester, the leader of this group. She's the provider reps relations manager. Anita is amazing. She's caring. She's knowledgeable. And she's here. So we want her to introduce her team today. Anita?
Thank you, Talisha. Good morning, everyone. Everybody's energized and ready for today. Yes, yes, and ready for answers. All right, so I have the honor and the pleasure to introduce our dynamic provider relations team. They are the face of Gainwell. So when you submit those contact us requests and in need of a visit, you have our fantastic provider relations team. But with every team, there's a great leader. And the provider relations team has a great leader. And her last name befits her. So introducing the supervisor of the provider relations team, Ms. Sharona Strong. Okay, now I will introduce the field reps. We have here on the screen the state of Georgia and the different territories. So I will introduce each field rep by their territory. So for Territory 1, we have Mercedes Liddell. Territory 2, which is all of Fulton County, DeAndre Murray. Territory 3, we have Carolyn Smith. That's Northeast Georgia. Territory 4, we have Tiara Johnson. It's Northwest Georgia. For Southeast Metro, that's Clayton, DeKalb, Henry, we have Ebony Hill. For Middle Georgia, we have Chantil Bradshaw. For Territory 7, which is all of Augusta, Miss Jessica Bowen. For Territory 8, which is Southwest Georgia, we have Jill McCrary. Territory 9, which is Southeast Georgia, Kendall Telfair. South Georgia is vacant currently, which is Territory 10, and we fill in with the current field reps. For the hospital field reps, we have the South and the North. So starting with the South field rep, we have Brandon Stewart. And for North Hospital rep, we have Sharita Bentley. Now I introduce our in-house reps. Our in-house reps are not the reps that's actually out in the field, but they are assisting the field reps inside. So with any internal things that they need, the in-house reps are here with the boots on the ground as well. First, we have Chastity Barrett. Next, we have Crystal Gordon. Next, we have Haley Guyton. Next, we have Latanya Durden. And last, Kaylin White. All right, next I'll introduce our statewide consultants. Our statewide consultants, they don't have an assigned territory, but they are throughout the state of Georgia, with a lot of our escalations and some of the providers who are out 50 miles outside of the Georgia state line. First, we have Brenda Hewlett, Danny Williams, and Janie Griffin Weaver. Okay, next I'll introduce our provider enrollment, CVO, the credentialing field reps. We have two of the reps for North and South. First, I'll introduce the South, which is Darlene Barna. And for the North, we have Auburn Woods Hawkins. So I introduce to you again our provider relations field reps and team. Thank you. Okay, you all.
Speak louder because it sounds like, okay, great. What you do every day isn't easy, but it's impactful. Your perseverance, your coordination, your dedication, your drive, your passion for what you do every single day set a standard of excellence, and we appreciate that. I often say that you're the bridge between DCH and the providers, between Gainwell and the providers, and that's so true. Why do I say that? Because you're the outreach for DCH. You're the problem solver for the providers. You're the face of Gainwell Technologies, and we appreciate you. I know sometimes it feels like what you're doing is going unnoticed, but it isn't. We appreciate you. We want to say thank you for every day being there for us, being there for the providers, being there for DCH, being there for everyone that needs you. Because of you, you make us better. Because of you, we can serve the member population in the state of Georgia the way we need to. Thank you, thank you, thank you. Continue being amazing, and we appreciate you. Give them a round of applause.
Okay, now we will have Sharona Strong, and she will
So
introduce
today-
some of our enhancements.
Yeah, so today, before Sharona starts, team, we're not here just to get a bag of swag. We always come to the Medicaid fair, we get swag on top of swag, and then we go dump it at the house when we get there. That's not what today is all about. Today is about meeting new people. Today is about networking. Today is about gaining insights to help us continue delivering quality services to the members of this great state of Georgia, right? People often ask me, Talisha, why do you do what you do? And I say, waking up every day knowing that I can make a difference makes it worth it for me. If I'm making a difference for DCH, whether that be Gainwell Technologies, a member, a provider, a CMO, any external vendor, it's a difference. That's why we do what we do. We're not here because it's a task for us, because it's a hobby for us. We're here because we love what we do, and we love serving the members of this great state of Georgia. We have a great DCH Medicaid team that creates great policies and procedures for us and makes sure we stay on top of our game. And we appreciate that. Now, with making a difference, there comes change. Everybody doesn't like change. Change is hard sometimes, but sometimes it's necessary. And I challenge each of you today to have an open mind, to be willing, to be flexible, to say, what can change do for me? Change is our chance to do something better than we've ever done before together. Remember that. Now, with that, just like the provider rep team has raised the bar every chance they get, the overall Gainwell Technologies team has done that as well. We are always seeking to improve our technology, to put enhancements in, to make it better for each of you. Why? Because it's important. We want to make your jobs easier, not harder. We want to do the right thing for you and for us. But at the end of the day, it's about what we do each and every day to serve the Medicaid members of this great state. And with that, I'm going to turn it over to Sharona so she can talk about the enhancements.
Good morning. Good morning. I hope everybody is doing well. I know some of you cannot see me because some of my team has pointed out that I'm short, and yes, I have on heels, but I promise I'm here. So I'm going to talk about a couple of new enhancements that you all have already started to take part in. Some of you may not have, but this is an opportunity for you to learn what is happening and what is changing. So let's get started. Ooh, I'm sorry, wrong button. My apologies. So there has been a lot of conversation. We've done a lot of webinars. We've tried to reach out to the community to let you all know that we are transitioning over to what we call group enrollment. So what the group enrollment does is captures the MPI for the billing group. So yes, it sounds a little cumbersome. Yes, it sounds a little strange to say a group. But just think about any doctor that comes into your office. If you have a doctor in your office, you're going to put them in your group. And with that group, you now can bill with that one singular billing apparatus. So it is already in works. It started July 1 of 2025. So if you have not heard about it, today is a great opportunity for you to learn about it and to see what you need to do collectively as a company or an organization to get your group enrolled so that you won't have any hiccups in the future. Now, of course, there are denials that are already happening when it comes to group enrollment. If you have seen some that says that your NPI is not associated or you're not attached to the group or something to that effect, it's because maybe you've already started the process and it just hasn't completed. But keep in mind that when you're seeing some of these edits, at the forefront, they may just be informational, and once that group is established, there will be actual denials. If you have any questions about it, we have a provider enrollment team here. We have DCH enrollment as well, so we'll be happy to answer any questions you may have regarding the group enrollment. Next, we're going to talk about viewing your letters on the GAMIS portal. I know that you'll get emails that say you have a letter, and sometimes you have questions about, well, where is it? I never got it, haven't seen it, where is it? So now, starting December 4th, when you're viewing your letters on GAMIS, it will be an enhancement where you can do a search feature, and it will bring up all of the letters within that search, and it'll be listed by the first or the most recent date. So to make it a little easier for you to be able to find the letters that we're sending out, and so that you get the notifications that you need in a timely manner. And I would be remiss if I didn't stand here and remind all providers, if you have not revalidated your account and the system is telling you to do so, please do so. My team is painstakingly going through 70,000 providers who have not revalidated their account. If that sounds like something you don't know anything about, come see us. Let's talk about it. Let's figure it out. 70,000 is a lot. So we want to make sure that all the information that we have for your group is correct. It would have come in a letter to say, hey, you need to revalidate. You may have missed that letter. That's okay. We're here to tell you if you got one. We'll let you know, and we'll let you know exactly what you need to do in order to revalidate your account. So please, please, if you're not certain, reach out to one of the team members. We'll be happy to look it up so that we can clear your account and you can get off the list, all right? Well, that is all I have, I think. Yes. So I will turn it back over to Talisha for her to do the metrics for Gainwell. Thank you.
Thank you, Sharona. Thank you, thank you, thank you. So I'm not going to go over every single metric that you're going to see on the slide because it's a lot of data. But metrics are impactful, right? We need to see what we've done since the last time we met. And that's what we're going to cover today. The data that I'm going to share with you is from May 1st through October 31st. And I'm going to do just a couple of highlights. So basically, we've done over 17,785 provider contacts from our provider relations team. That's a lot. We've taken over 535,000 calls in our provider call center. We've also taken over 73,000 calls in our Georgia Families Call Center. As it relates to provider enrollment processing, we're currently processing applications within 13 days of receipt, and CVO is 25 days of the 51-day SLA. As it relates to resolution and adjustments, we're currently processing adjustment requests received within 10 days of the 30 days allowed. And as far as the mail-outs, we've had over 2.3 million mailings that has been sent out of our mailroom. That's a lot. That's a lot. So it's important for you to understand the type of work that we've done and what we've been able to accomplish. But we can't stop there. We've got to go further and further in this Medicaid game. Because what we have to do is we have to keep raising the bar, raising the level, heightening the expectations that we have for each other so that we can do the right thing. Now, my favorite slide of all slides is about teamwork. Teamwork equals success. That is so true. None of us are here because of us. We're all here because of teams. We're all here because of each other. And it takes all of us to do the right thing. My motto has always been, teamwork is the key to success. Why do I say that? Because it takes our providers. Basically, our providers are the front line of healthcare for us. DCH is actually the backbone to Medicaid, right? Of course they are. Gainwell Technologies is actually building complex systems and providing exceptional customer service. That's what we do every single day. The CMOs are actually there to improve lives, and the vendors are there for us to collaborate with. It's super important that we all work together to achieve teamwork. Why is that important? Because that is the driver for us. There's no I in team. There's no I in team. We've all heard that. We've all heard that. And the reason why we have to work together is because we all have a common goal. That common goal is making sure that we serve the members of the state of Georgia. Yes, you're going to keep hearing me say that. Why? Because that's important. The members are key for us. The members are the heart of everything that we do each and every day. The members need us to continue building policies and procedures, making system enhancements so that they can get the services that they need. The providers need us. Our vendors need us. DCH needs us. We all need each other. And the reality is that we should be proud of what we've achieved so far. I'm super excited about that. But we can't stop there. We have to keep building and making a stronger foundation for us and all of our members. So team, for those of you that have colleagues that missed out on this wonderful opening, yep, that's okay. They will be able to see it. The presentations will be uploaded on the GAMIS web portal by close of business tomorrow. The session FAQs will be uploaded within 2 weeks. Now, if you want to see the FAQs, you can visit the mmis.georgia.gov site, and you can go to provider information and then, of course, provider notices. Other resources that you need to be aware of is that the GAMIS banner messages are placed on the mmis.georgia.gov site. The DCHI newsletter is at dch.georgia.gov/dch-i. If you want to subscribe or request to be added to their distribution, please use the DCH-I at dch.georgia.gov. With that, I'm going to turn it over to Mr. Stuart Portman. He is Executive Director of the Department of Community Health. He has a wealth of information, and I am super excited for you guys to hear what he has to share with you, and hopefully for those of you that shared your insights with us, you get exactly what you were looking for. Stuart?
Good morning. You know, I gotta say, I was ready to do a little bit of hyping up, but I don't think I need to. I think we are all appropriately ready for this exciting day. So I'm Stuart Portman. I am the Executive Director of the Medical Assistance Plans Division here at DCH. That is our title for Medicaid Director here in the state. We're very excited for the conversation today, having these provider fairs to understand a little bit more about what current issues are going on in Medicaid, trying to get some answers and knowledge and build those connections is a unique opportunity and one that we don't take lightly. So we have a lot of exciting things to share here today. For those of you that have come to these in the past, when I have given a presentation, you might know we always talk about some of our current initiatives. I will give you a little bit of a heads up. Today is a little bit meatier. In case you were unaware, healthcare and politics have been a big conversation since the spring Medicaid fair. And so we are going to share some of those takeaways for all of you so that you have a little bit more to understand, share with your colleagues and peers, friends and family, make sure everyone has a sense of what's actually going on here on the ground. And then we will have a bigger conversation about some other initiatives going on within DCH. So this will be a slightly longer session than it usually is of just 30 minutes. And then we will break, go into some really great items on the agenda, some really good sessions. Of course, each of the CMOs, and then 3 other sessions spread throughout the day. We hope you all take advantage of all of them. There's some really great discussions to be had, and I know while I could speak for a long time about the importance of each and every one of them, we always know that conversations on common billing denials is a very important session that a lot of folks like to attend, and so we know that is, I think that's referenced in some of the registration numbers as well. That one seems interesting to a lot of you. I will just say before we dive in that it is also worth remembering the reason that we are here doing what we do. There's a reason we all work with the Medicaid community and serve the Medicaid member. We have worked hard at DCH to really refine our vision and our purpose, and that vision is always, always about being member-driven. There's a lot of day-to-day operations. There's a lot of things that are changing. Talisha did a great job explaining the fact that change can be challenging. Most people don't wake up in the morning and say, I'd like everything I do to be different than it was the day before, and we don't want that either. But we do know that there are changes coming, some through the state and some through the federal government, and DCH can be a partner in making sure that those changes are understood and well articulated so that there is as little disruption to your day-to-day work as a provider serving this population as possible. So we are a member-driven payer of high-quality, cost-effective services, utilizing innovation and accountability to promote a culture of excellence. And we are trying to ingrain this vision in everything that we do, ingraining being member-focused in everything that we do. So as is customary for the Medicaid Fair, we have a poll. I will note that this time our poll is going to be a little bit different. And by that I mean, I will not ask about baked goods. For the last few times we've had this, there have been a lot of questions about which baked goods you like. That is not a question today. If you would like to scan the QR code with your phones, this is a participation component. So scan the QR code, or you can go to menti.com and use that code at the top. I'll hold it for a minute. The code will be on every slide. The QR code is just on this slide. Okay. There are 2 questions. There we go. So, the first question, because we're going to have a big conversation around rural health today, is how frequently do you care for people who live in rural Georgia? Answers are scrolling in. This is good. And daily is definitely the winning answer. A little bit of perspective, especially as we get into the bigger conversation today. The second question does fall a little bit more into Georgia pride. And it's which fact about Georgia is the most interesting to you? For those of you that did not participate, I will read them out loud because they're all great facts. The first is that there were 2 state capitals prior to Atlanta being selected as the state capital in 1868. The second is that we produce more peanuts, pecans, and Vidalia onions than peaches, even though we are the peach state and can be proud of that. The third is that the University of Georgia was the first state-supported university in the U.S. when it was chartered in 1785. And the fourth is that the CDC was created in Atlanta in 1946 with the primary mission to fight malaria. And that is the winning answer so far. Okay, this is good to know. I was warned by others on my team that UGA would win. They were wrong. So. Okay. So a few fast facts just to keep everyone up to speed. We have 144 employees within the Medical Assistance Plans Division, which if you think about all the things that go on in the world of Medicaid, should be a very interesting number for a lot of you. We are divided into 5 different offices, 5 different units: eligibility and enrollment, quality and population health management, policy compliance and operations, service delivery and administration, and pharmacy and laboratory benefit management. We have recently pulled out pharmacy and laboratory benefit management to be its own separate component, and we've done a little bit of a reorganization to make sure that the work that we are doing as a department can best serve the providers and the members. Our enrollment is currently roughly 2.18 million. That's combined CMO and fee-for-service. And our broader budget is approximately $18 billion. So that does continue to put us within, around number 10 in terms of the largest Medicaid programs in the country. Just, it's not a race, but it's worth knowing where we stand. We will not be California. So a lot of what we're going to discuss today is going to be around H.R. 1, the One Big Beautiful Bill Act, that passed on July 4th. It was the source of conversation for pretty much the entirety of this year. We're not going to talk about process and politics. We're going to talk about what became law and what actually is required of the state to implement to come into compliance with this new law. And there are different dates and different timelines, but there are a lot of things that start to require work on the front end. So first and foremost is the community engagement requirement. There are a lot of, there's a change for all states that expanded Medicaid and some language that applies to Georgia as well that requires us to come into compliance with a new standard of community engagement on January 1st of 2027. That change is actually very similar to what we already do as Pathways. We are the best situated state for this transition because we are the only state that has a community engagement program that is being expanded. However, it's not a perfect match. There are some changes, and we're going to have to work through what that means on the eligibility side. As of our most recent extension of the Pathways program in September from the federal government, from CMS, we now have coverage today for parents and legal guardians of children up to age 6. So that's a good thing for everyone to know, right? A parent or legal guardian of a child up to age 6 is eligible for coverage through the Pathways program for that time. However, over the course of the next year, we're going to have to update that to be for a parent or legal guardian up to age, or up through age 13, excuse me. So that is a shift as well. So there's a lot of, to the point of there are changes coming, we've expanded what the qualifying activities look like and who is eligible for Pathways. That's also going to expand again. There's also definitions of exemptions of different populations, and those definitions will change. And we will provide a lot of information. You're going to see a lot in the news about what this means. Know the impact on Georgia is different. There are not coverage losses from this policy in Georgia. There are changes to our coverage policies, and likely we will be making sure to be in compliance that everyone that can have eligibility has eligibility because of the federal law. The next item is related to provider taxes. We won't go into all the financing details today on provider taxes and state-directed payments, but we do have, as a state, we're a state that heavily relies on provider taxes. We are capped at the level that we have today. We can't change that because of this bill, which is frequently a way for the state to raise revenue in order to do new things. So that's a conversation that will be taking place. And the state-directed payment programs, we have 1 for physicians and 4 for hospitals, and have proposed another for hospitals as well. Anything that is new that came about after July 4th is capped at 110% of the Medicare rate for reimbursement, but there's a whole grandfathering methodology. Again, we don't have to go into that, but what that means is that there's an opportunity for bringing on these existing programs at a higher level than 110% of Medicare, and making sure that those dollars can still flow to our health systems and make sure that there's improvements in our broader workforce and care delivery and service lines. Additionally, and of note, there's a lot of eligibility-related changes. There's one explicit eligibility change in this bill, and it is the definition of a qualified alien, which is the language in the Medicaid statute. That is changed so that there are different categories of a lawfully present resident that no longer apply, can no longer receive Medicaid coverage. That is the only thing, and I'll bring this up again in a second, the only thing that directly impacts enrollment from this bill on Georgia Medicaid. There's also changes for retroactive eligibility. So right now it can be 3 months, it shifts to 2 months. And then there's some changes on home equity that don't apply really in Georgia, but can in other states. And there's, again, multiple changes in the community engagement space that will affect our eligibility and enrollment processes and some of the GAMIS work on the back end. So we will work to be in compliance by all the necessary dates. So I want you all to know that, but also understand that there are some changes that are coming from all of this. Additionally, and I would say importantly for this discussion, there is a component of HR 1 that is the Rural Health Transformation Program. It is new. It did not exist before. It is a $50 billion fund spread out over 5 years to all states that apply. And as of last week, which was the due date for all the applications, all states have applied. If any of you have ever been a part of grant-related work, then let me just tell you, there has never been a grant like this grant. Because we had to apply for one time as a state. Every state had to apply for their funding for 5 years, and we had 45 days to develop the application. That is pretty unprecedented, given that we were going for our share of $10 billion a year for those 5 years, which has, for a state like Georgia, has the ability to transform a lot of what we do. And I will go into detail of what we are going to, what was in our application here. We had to include in our an application that was very rigorous. I think it shocked states how rigorous the application was from the CMS. But it needed to make sure that we focused on prevention and chronic disease management, provider payment, consumer technology solutions, training and technical assistance, workforce, advancing IT, improving care delivery, behavioral health, and more innovation. We got like I said, the bill passed on July 4th. The formal notice came out on September 15th, and the deadline for submission was November 5th. It is evenly divided into $5 billion a year for all states, which equates to $100 million a year for 5 years, and another $5 billion a year that's competitive based on the rigor of our application. And that is where we think Georgia can stand out. We are a state with a lot of rural area. We are a state with a large rural population. As evidenced from the first polling question, our providers spend a lot of time caring for rural Georgians, and we made that very clear in our application. We've also included a lot of input, and we've done that from the beginning. The input process, because of this condensed timeline that we had, began in August, before we even had the formal parameters, because we needed to make sure that we didn't waste any time. And I will say it is, we'll see what this means at the end of the day when we get our award, but it seems like it has played to our advantage because we've gotten a lot of positive feedback for being a transparent state with a transparent process all the way through. We had an online form that anyone could provide information to. We got about 150 ideas, a little over that, on time, and about another 60 that were not on time, but we still reviewed them. They just weren't formally captured. We also had 4 town halls, 1 that was virtual, and 3, importantly, that were in-person only around the state, in Cordele, Jasper, and Vidalia. We also had individual meetings with all of our sister agencies, the university system, and tried to bring in as much input as we could to put together this application on the part of the state. Again, as part of the application, we needed to think about how it could be transformative in nature, but also all the ideas needed to have the potential to be one time. Even if they were going to be repeated over those 5 years, when they go away, everyone had to recognize it's going away and it's okay. And it needed to support the overall health goals of the state. So the biggest constraint there, and that first one, which is what I wanted to emphasize today, we had to do things that could be both transformative and considered one time. CMS was very clear in their various rounds of frequently asked questions that we could not increase rates with these dollars. That is not considered something that is one time. And I will say, as much as it may frustrate folks when you see this money and thinking about ways to increase rates, I think you would agree that no one likes to see a rate increase and then a year later watch it go away. That is not something that generally builds goodwill amongst the state. And importantly, and we've had many conversations with the General Assembly, is we cannot supplant existing state funds or appropriations. This has to be on top of what the state normally does. So our program is called the Great Health Program, the Georgia Rural Enhancement and Transformation of Health Program. We're happy about the name. You're going to see a lot of great health. It's going to be a lot of places because we think we're going to do really well. We think that CMS encouraged states to fight for their $1 billion of this. We think we are going to at least hit that, if not get a little higher. I'm the optimist of the team. I will openly say that I think we're going to do really well in that competitive portion of this grant opportunity. The 5 strategic goals are transforming for a sustainable health system, strengthening the continuum of care, connecting to care to improve healthcare access, growing a highly skilled healthcare workforce, and leveraging technology for healthcare innovations. Each of these initiatives is comprised of various strategies to help our overall goal of improving the health of the state and creating this more sustainable path forward that is transformative. Our broader vision through this program that will work with providers across the state is to support rural populations and make sure they're healthier, live longer, and have an improved quality of life so they can both live and work in the communities they love, to make sure that rural places have healthcare that is high quality, more abundant, and more effective, and push for rural progress that creates systems-level changes that leverage technology, drive innovation, and improve quality, all while maintaining that patient focus and patient voice. And as it relates to the populations this applies to, many of these provisions will be focused on, based on a definition through the Centers for Medicare and Medicaid Services and the HRSA, those 2 agencies that have a more of a rural focus. It focuses on around 126 counties of our state. It is a broad-based understanding of what is rural or rural referral. So like I said, there are 5 initiatives. In order to be transformative, we took the bull by the horns and we said, there is an existing model of care that exists through the Innovation Center at CMS. And one of the #1 pieces of feedback we received in person and online was use these dollars to push the state into value-based care, but in a way that works. Not value-based care that's off the shelf, but value-based care that shows that there's a business case to care more about outcomes and a business case so that the providers can do what the providers want to do, which is care for the patients, knowing that they're improving care, but also that we're no longer living within a fee-for-service mentality. And even as we blend that with the work that's been going on with our CMOs, we saw the opportunity that is there. And we got that piece of feedback, I would say, most frequently. And so we took that idea to heart, and we are blending the Rural Health Transformation Program, our Great Health Program, and this existing model of care called the AHEAD model through CMS, and we are creating an on-ramp. We are creating an opportunity to bring care across the state in those 126 counties into a more value-based context and value-based design. It is very complicated. You all will hear a lot more because you all will particularly help make sure that we are successful, especially, I will say, outside of the metro Atlanta area. But there are ways in which those within the metro Atlanta area can support a lot of these initiatives, particularly when we get into conversations related to telehealth. So there's a lot of interactions, and that is why we view this as more of a statewide function. But I say that because our first strategy, which is transformation that is sustainable, is built around that AHEAD model to make a financially viable case for rural hospitals to stay open, for rural providers to build out their practices, and to make sure that we shift our focus to patient outcomes across the state. There's a lot of funding in this particular initiative at assessments of all of our healthcare for our healthcare providers, because you got to know where you are if you're going to talk about transitions to rural health. And you got to know where you are in terms of your finances, and you have to know where you are in terms of your technology. And this is not a let's make ourselves look really good. This is a where are we, look in the mirror, understand our needs, because this is an opportunity for us to invest in improving the infrastructure of the state so we can make these changes. The second initiative is all about the continuum of care. And there are a lot of strategies here. There is public health investments, both in terms of building out lab capacity and making sure that there's some redundancy in our lab capacity for newborn screening in the state, making sure there's more inter-hospital transportation to get patients between hospitals more readily, that we add support for those with, for survivors of brain injuries, that there is an expansion of a pilot for transportation to treatment for those with mental health crisis, so that we're not relying on our sheriffs to be the drivers in that situation, and we can keep care in a more appropriate medical setting. There's a school-based healthcare services infrastructure expansion, which is building out the availability, and this will be statewide of note. Some of these may or may not be, but this one definitely is. And it is making sure that every school district has the policy parameters and IT infrastructure to decide to offer school-based health the way they want to. Whether they're a full-on Apex school that wants to have an on-site clinic, or they're a school district that has nothing but wants to have a relationship with a local provider, FQHC, hospital to help provide some care when needed. All of that infrastructure can be developed through this, so we have some rules of the road on what it means to do school-based healthcare in the state of Georgia. There's also this component that's, I can tell you, quite popular. It is under the guise of emergency preparedness, because that is a way that it actually makes sense to do this, but this is physical infrastructure improvements to our hospitals and nursing homes in rural counties. And we are going to do an assessment of every rural hospital and nursing home to determine where they are and what their needs are: electrical grids, roofing, air quality, water quality. Do they have a generator? Do they have the hookups necessary for a generator? Does the electrical grid support a generator? All of those pieces to make sure that when we have severe weather, when we have to make sure that there are transfers of populations from one setting to another, that we have the right capabilities as a state to handle those situations. So really a good look in the mirror and an improvement in our state. There's also going to be some work to make sure that nursing home transportation can be enhanced, especially, this is not going provider to provider, but this is trying to make sure that there's some broader transfers that are needed in the nursing home space. There's also some training for autism spectrum disorder providers about nutrition and the importance of nutrition, and we're developing a training that can be provided to all of those providers. And then within the Planning for Healthy Babies program that we have today, there's going to be an expansion of the existing eligibility pathways to say that if you are a pregnant woman who meets certain clinical criteria, you will be moved from traditional pregnancy Medicaid to this new interpregnancy with nutrition pathway, and you will get nutrition counseling and likely access to a GLP-1 as long as you are no longer breastfeeding. So this is a shift in broader policy. It is through this waiver. As you can imagine, there's a lot of conversation in the GLP-1 space, and happy to dive in further, but we know there are a lot of adverse maternal health outcomes that occur, particularly between pregnancies, for women that are overweight or obese, and there are opportunities to improve upon that between pregnancies so that the birth is healthier for both mom and baby. And that is the purpose of this policy. As we talk more about additional ways to improve access in this application, we're going to expand, based on the request of FQHCs and hospitals, telepods that can do 24/7 primary care and behavioral health care around the state, as well as enhanced mobile clinics doing a variety of different things. They can be physical health, it can be dental, it could also be behavioral health or mammography or other scans, based on the desires of the community. And DCH would build out the mobile clinic and give it to the community to maintain and operate. But that is how we can use these funds to handle some of those startup costs. There's also a significant enhancement to telehealth. And I mean in terms of the services that are provided via telehealth and the technology and availability of those services around the state. The rural stabilization grants that are offered through the State Office of Rural Health would be built upon further through this funding. We would also be creating, through the Department of Public Health, a standardized OB cart for all non-delivering hospitals to help improve our standard of care for emergency labor and delivery, so that there's at least a stronger protocol in place across the state. And we would build out those, stock those carts and deploy them across the state. There's also going to be telehealth infrastructure within our county health departments, and some rural telepsychiatry work specifically within a model through Pediatric Project ECHO with DBHTD and with pregnant women through their Peace for Moms program. The fourth initiative is all about workforce. So there are enhancements through GME, whether it is graduate medical education expansions for new and existing programs, and some recruitment incentive grants for doctoral level providers to come to the state and to come into practice in rural areas. There is a whole slew of nursing care improvements, particularly focused on making sure that nursing faculty recruitment is stronger in the state so we can actually have the right staff to train our future generations of nurses. There's virtual provider education on dementia. There's training and housing for the AHEC program to help with skilled allied health professionals, especially starting at earlier ages. There's a lot of programs in the state starting at the end of high school for those that know they want to enter the health profession. And this is making sure that when they get those trainings, they have a place to actually live. So that's not a barrier to them getting the training that they want. And then scholarships in the EMT and paramedic space. And finally, our fifth initiative is all about leveraging technology for innovation, and it includes cybersecurity enhancements across the entire state, so we can all have confidence in our cybersecurity. It includes EMR enhancements, which I think it's going to be a very exciting opportunity to take a look in a value-based care model and say, if we're doing value-based care, what are the modules, add-ons, base systems we need to be successful? Population health indicators, does our system do that today? Or does that need to be fixed? And in this rare instance, based on available funding, I have to add that part in this one in particular, we will just have the ability to pay for those enhancements and make the transition focused on care delivery and systems integration and not on can we afford the system, which we think is a pretty exciting opportunity for providers around the state. There's also this Catalyst Fund, which you can think of as a dedicated venture fund focused on incubators and early stage companies that are investing in technology that supports rural health. So there's dedicated funding to build that out, to bring more technology into the rural health ecosystem. There's support to bring robots, surgical robots, into rural hospitals that have an interest in having them, because much of the training that occurs today involves robots, and rural hospitals frequently don't have that capability. And so this would bring, we would be able to pay for the robots to go into those hospitals that are interested in having them. There are some eligibility system enhancements throughout at the state level to make sure that we can be more streamlined in our eligibility processes. And there's some broader consumer engagement enhancements, because in all value-based care models, you need the actual member to take ownership of their health. And you have to make sure you have a data system that can support that, and that there's an interface for them to support that. So that is a very big AI-enabled space for us as a state. We also would do a statewide assessment of all technology for behavioral health and areas where additional technology would be useful for supporting our behavioral health providers. And then a broader EMS treat versus transport proposal, so that we can make sure that all of our EMS vehicles are equipped with the right technology to treat people where they are, if they can be treated where they are, and they don't automatically have to be taken to an emergency department. So that is a lot. I will tell you, we have 29 separate strategies under those 5 initiatives. We've talked to other states. Most of them have like 10, 12, 15. I know one state has 20. We went big. We were told to be bold and transformative, and we did. And I hope I didn't lose you going through all of that, but I'd rather you all understand what we are trying to accomplish and the ways we're trying to accomplish it, so you understand there's a vision behind all of the work that we are doing. And this is, just to add a note, this is on top of everything else that we are already doing at DCH. That will not change. But because this is a very quick grant, you're going to hear a lot about it very soon. It was due, the application, on November 5th. We will find out by the end of December what our award is for each year of the 5 years. And so implementation activities are going to begin rapidly. We're going to have a lot of implementation for every one of those 29 projects. We're going to have to formalize a grant-making process for every one of those that allows for either a hospital or individual provider to receive funds. So we have a formal process for you to get money to do those things. And we're also going to have to bring on some staff to make sure that we can make this more seamless. And we, of course, will try to do that as quickly as possible. As a general note, this program being new and passed in July is an exciting opportunity, but it does not change the role of the State Office of Rural Health. SOAR continues to operate in the way that it has. It will not change in any way from what they are currently doing. They will take on new responsibilities to help. MAP, our division, will also take on some new responsibilities for a lot of these projects. We will work in conjunction to make sure that we can achieve the goals that we have outlined, but SOAR will continue to do all of their other programs as well. For the sake of time, I will not go into the rest of the things that I was going to say, so I have time for Matt Gerard to share more about our MEST program or project. But I will note that there are three things I intended to speak to that are current priorities that are moving forward. One being PACE, which we've talked about in detail at previous Medicaid fairs. The other being behavioral health. We have multiple new models of care that are coming into practice that have gotten passed through whether it's a state plan or whether it's through needing other forms of CMS approval, but we are moving forward, and our first certified community behavioral health clinics are going to be coming online in January, which is a great opportunity to expand the service offerings beyond what can be currently done through a CSB. A lot of the CSBs are making that transition so that they can provide those services more comprehensively in the communities. So there's a lot of information to come on these models, and we are doing a deep dive into maternal health as another priority area so that we can make sure that there are a better understanding of the provision of services, coordination of care, data lags, and the point at which women are starting to receive services, because the data we're receiving shows that there's a lot of opportunity and necessary action on the part of the state to highlight and address so we can improve outcomes here. So we are still laser focused on these broader components, but wanted you to know what we've been doing since July. Figured it's a good opportunity for you all to get a sense of what that means. I will also plug the reminder to make sure that we have our revalidation efforts underway. Always important. We have tried to work together with Gainwell to do as much automated review as possible, but there is going to be a date certain. I have not said this in the past. There will be a date certain where revalidation must be complete. That is coming, which means if you are not doing your revalidation by date certain, that's not good. And please continue to speak to your patients about pathways to coverage, especially as it has expanded with our updated qualifying activities. So I'm going to turn it over to Matt Gerard to talk about our Medicaid enterprise system transformation. He'll speak, and then at the end, with whatever time is remaining, we will take questions across whatever we have said. Thank you.
Good morning. So I had a little coffee accident coming in here. So my notes are blurry. So if this doesn't go well, that's what I'm going to blame. It's the coffee. Got a lot of providers in the room, it sounded like, which is great. This is mainly for providers. I think the DCH folks and the Gainwell folks may be aware of what I'm going to talk about. But anybody obviously can ask questions. This is going to be a high-level overview. I don't have a lot of details that I can talk about right now. A lot of things aren't in stone, but definitely be open to questions. So I'm Matt Gerard. I'm the senior advisor to the CIO at DCH. I've worn quite a few hats over the years. One of the titles that I have is Medicaid Enterprise System Chief, and that puts me over the procurement of Medicaid systems and the MMIS, the legacy MMIS, and enhancements and changes that come along with that. We are looking at, let's see. There we go. That's back. There we go. We have a program called the Medicaid Enterprise System Transformation. And the key word there is transformation. How many people have heard of CMS mandate for modularity and interoperability? Maybe some hands. So those are actually interrelated. The modularity concept goes back, really it's a MIDA concept. It goes back to the Bush administration. It's part of an overall initiative by CMS to introduce more interoperability, to introduce modularity into the MMIS ecosystem, which means they want us to be able to break down the MMIS into component parts that are interchangeable. So that means going from a monolithic system to a more modular system with potentially from a single vendor to multiple vendors in that space. It also, and this is near and dear to my heart, it means connecting other systems that maybe are not part of the MMIS or that are part of the larger MMIS ecosystem into one overall system. In other words, those systems wouldn't be siloed, they'd be connected and be able to exchange data and information, hopefully in real time. So we're trying to rethink what's possible, and that's gonna better serve our communities and comply with federal requirements. We should be doing this whether the feds are requiring it or not, but they are requiring it. They will no longer invest in these monolithic systems, and that's been very clear. They left it pretty open-ended, or largely open-ended, to the states how we implement this, which has been great because the states, all 50 states and territories are working on this right now, and they're all slightly different. If you've seen one modularity program, you've seen one modularity program. Which is great. There's been a lot of innovation. There's been a lot of creative thought out there. When we get together at conferences, we're kind of amazed what's going on. The vendors have lots of great ideas and have put forth a lot of innovative solutions. So we're excited about that, and we're excited as a department about what this means for us. So it's going to be an enhanced experience for providers, ultimately for members, but also for state users. And everyone that's involved in these systems. So what is modularity? I mean, what does that really mean? You see those building blocks on the left there. That's to represent individual modules, individual systems, individual applications that would all be part of a larger whole running off of what we're calling an integration platform. Connecting the tissue of all of those systems. But they're independent enough that they can be changed in and out as modules. And we have guiding principles in this initiative, one of which is loose coupling, which is just a technical term for being able to interchange systems. So we'll have a lot of things that are centralized. There'll be things that modules do on their own. There'll be things that systems do, but everything will connect. It'll be incremental, rapid, some of the benefits will include incremental rapid updates that reduce time and effort. We'll have accelerated change and new policy implementation. This system should be able to be more nimble than what we've been used to. Also, it's going to be a more scalable, interoperable system with faster access to data and information. As I said, there are systems outside of the MMIS ecosystem now that'll be connected to this. And that will make things a lot easier for everybody. It's going to be a more user-friendly, one-stop shop. The platform that we're building will be a one-stop for everybody, providers and state users and our partners. And really, it's going to be more flexible and cost efficient. I like to talk about it in terms of increasing value, so that we're getting more for our investment. So Georgia Care Connect is what we're calling this. We built a portal. It's out there. You can go look at it. And I'll give you the address before I leave. But ultimately, providers, state employees, and users, our partners and other agencies, they'll go to that portal to access all the new systems. That will include GAMIS at some point, probably next year. Everyone will have to go through that portal. Part of modularity, as I said, was breaking down the MMIS. A couple years ago, we put out a procurement for a provider module, which is a provider services module. We've awarded that and are implementing that system now. Sometime next year, we will start to roll out information about moving to that vendor. But our goal is that it is as seamless as possible. We do not want it to be disruptive to users or providers in particular, which means we're going to be soliciting a lot of input over the next year or so. And so the main goal here today is to let you know that this is happening. And our overarching goal here is to get input from users and providers. We've already had one of our partners reach out to a set of GAMIS users to look at some human-centered design on that portal. So we've already started that outreach. So just moving right along. We'll talk a little bit about the way we're rolling this out. If I can get this to advance. So we're release-based. This is an incremental approach, and we're rolling it out in, it doesn't really matter. We're rolling it out in releases. Those releases involve different things. Recently, last week, we rolled out a release that takes the nurse aid and medication aid information off of the, off of the GAMIS portal and moves it, actually moves it the way you access it from the GAMIS portal to the Georgia Care Connect portal. And that was a successful release. Anybody that's tried to access nurse aid or medication aid information has already been through that. That should have been totally seamless for the users. It's just that they go to a different place. We're going to have some future releases that involve Georgia families and CMOs. We're getting ready for that now. Everything we do will be focused on implementing CMO when it starts. We will be looking at, as I said earlier, about the provider module going live. Don't know when that's going to happen, but maybe by the next fair we'll have some dates and a roadmap ahead in the spring that we could talk a little more about. But again, this is what's happening. And we wanted people to be aware of that. As for what it means to you, well, more information will be coming, as I've said, so keep an eye out for communications from the department. And I would also encourage you, if you haven't, to go to the portal. And it's careconnect.georgia.gov. And from the portal, if you want to submit information or requests, you can go to the Contact Us, and where it says Contact Us, you can actually submit a request for information. That'll come to me, probably. So we're excited about this. It is a mission-critical initiative for the department. So we look forward to being able to tell you more about it in the not-too-distant future. anybody have questions? No questions? Yeah. I don't know if I can hear you, but.
Like connections for other states, since some of us are out-of-state providers. Is this going to integrate with other states, since you said this was a national program that was required?
Well, to access Georgia Medicaid, you would just use a new portal.
But are you going to communicate, is the same information going to communicate out?
Yeah, ultimately, you would access Gainwell's tools through this portal when we move those over, which would be next year, maybe the year after. Don't really know what the date on that is. But yeah, if you're an out-of-state provider, it'd be the same. You would just be accessing it through the new portal. Does that answer your question? I didn't understand the question, I guess. Anybody else? Yes?
So if there will be interoperability with healthcare networks, will down coding sort of be limited because you'll be able to see the medical record and, understand the time, complexity of a visit?
I'm not sure I understand that. Could I? What was it? Down coding?
So I'll jump in.
Go ahead.
So I would say, I think I take your question to be a little bit more about the interoperability as it relates to sort of EHRs and like care delivery, whereas this is more interoperable at the systems level and not talking about the provider level type of change. There's provider components to understanding how we can actually review all the necessary billing components, but I think what you're asking about is a slightly different question than what this system is intended to do. However, it's a fair question that we can take back and build out in some of the policy discussions that we have.
Yeah, if I may, I was just, because it said it would interact with healthcare systems. So if it's not the electronic health record of that system, are you saying it's just, like, what then, I guess, are the key things that it's touching in a healthcare system?
So right now, it's touching what we think of, it will be touching what we think of as GAMIS. So which would be the MMIS, would be provider enrollment, claims, payment and adjudication, data warehouse, TPL, other tools that we use in the MMIS area. If you're asking about GHIN,
yes.
We will be connecting to GHIN. We're talking about that now. So there's definitely lots of opportunities there.
Right.
So. Anybody else? There was somebody back there. Yeah.
Oh, as a provider, will all of our information be automatically integrated over, or will we have to go this process again of trying to get all of our information and everything over? Like, how is that gonna work? And will we know exactly, or will we try to log in one day and it won't work? And it's like, oh, you have to go to the new system. Will you guys keep us updated? Can you kind of give us a blueprint of how that's gonna work?
Provider information, you're asking?
Yeah, pretty much.
Yes. So the new vendor will convert all of the information over. We want to make it as easy as possible for you, providers, to log in and just verify that that's correct. We'll do that. We'll start talking about that next year and what that looks like. And again, that's the kind of stuff we really want some feedback on. If we're putting an undue burden on you, please tell us. We can probably come up with an easier way. We'll do it.
Multiple provider numbers, will it all be together, or will we still continue to have multiple logins like GAMIS?
I don't know. That may be a question for him.
If we can find a seamless solution to that, we know that is a problem that has been raised in the past. So if we can find a way to address it,
so I think. If you guys could figure that out now so that we can know to make it easier, that would be great. To put everything in one hub will be awesome. So
we will take that feedback. Thank you. There's another question up in the front over here. And the questions can be broad-based. They can still be on this if you got them. They can also be on any of the other pieces that were mentioned this morning.
I was just wondering, oh, that's loud, sorry. Good morning. I didn't see anything about eligibility and benefits. Is that going to be on the Georgia
eligibility
portal?
And benefits. Will that be a part of this?
Can you hear me? Sorry. Eligibility and benefits for the providers. I didn't see that as an option on the portal, the new portal.
Like gateway eligibility benefits, you're talking about?
Like right now we can go on GAMIS and we can pull up, okay, the patient is active, do they have a copay, that kind of stuff. Is that gonna be on this new portal as well?
Yes, member information will be one of the key components, just like it is in GAMIS.
My question is more along the initiatives that we were overlooking. The EMS treat and no transport, is there going to be changes, or is it still going to be medications have to be given?
The specific proposal there, and fair question, the specific proposal there is about building out the technology of the vehicle, not about the policy specifically.
So it's more along the lines of
it's
the
more
upkeep and such of the ambulance and that kind of thing.
Correct.
And what they have to offer.
That's right.
Is right? Okay, got you. Thank you.
Hi, my question is about the status of the CMOs. You told us last fair that you would talk about the procurement of the CMOs. We're getting, as providers, we're getting a lot of requests from these new CMOs that potentially are coming on. They're kind of want our rosters. They want all the information. What is the status?
So we are still under a protest period based off of the prior notice to award from last December. The Department of Administrative Services is working through that protest process, and until it is completed, the department is not able to share any additional information. Once we are out of that protest period and we have some sort of resolution, we will happily be able to discuss in more detail what that actually involves.
So do we acknowledge these new CMOs that are coming on potentially? Do we give our rosters? What do we do?
You are not obligated to do anything until there is any sort of a notice of award and a final determination. I can't advise what you can or can't do during this period, unfortunately. However, there has not been a confirmed notice of award as of this date.
With these potential new CMOs, how are they going to handle transferring all the prior authorizations, or are we going to have kids on hold to get all new prior authorizations?
We have a very significant implementation plan that will involve providers, it'll involve CMOs, it will involve everyone involved across the state, because this is has a potential to be a large lift, and we would have at least a year, if not an 18-month window, to make sure that we can have that transition take place appropriately.
I have a question over here. Regarding the new CMOs, I know you said that we can wait to do the paperwork. I've already been told by one of them if we didn't do it now, they were pausing everything till January, February, which is fine. Some providers are concerned that if you wait to do it, they're going to be like Peach State when it comes towards the end and say, oh, we're only going to give you an 80% contract, not the full CMS rates now. Are you guys doing anything to prevent CMOs from doing that to providers in the future?
So I can't speak to that particular piece at this point in time, but I'll take that back to the team.
We got a question over there.
Okay.
Just a quick question. I received a call from one of the CMOs that a client had a complaint that we did not transport them to doctor's appointments. So I'm wondering, is that going to affect us in any way? Because we are not required to do that.
So I think I only heard a portion of what you just said, but I can follow up with you when we're done here about that specific concern. So I'll say, I think I see one more question back here, and then we can get ready to close out. And I will note as the microphone's going over, because I forgot to say it before, if you have specific additional questions or would like to learn more about the Rural Health Transformation Program, it is on our website. And if you go to dch.georgia.gov, you will be able to actually view the entire application narrative that has much more detail on each of these specific proposals if that is of interest to you. But I saw one question back there. Oh, great. Okay. Then I'll say thank you to everyone. I'll pass it back to Talisha, and know that I know this was a lot of information to throw at everyone this morning, bright and early, which is why I'm glad Talisha got everyone pumped and ready for the day, and the provider reps got everyone pumped and ready. We have a lot of great sessions planned. There's a lot of coffee.
Absolutely. Absolutely. Absolutely.
Thank you all.
All right, all right, all right. I know everybody is ready to go because you're excited. You're ready to get to the next sessions. I have a couple logistics things that I'm going to share with you first today. When you go out for lunch, basically the gate should be up for you, so you shouldn't have to worry about having to do any payments or anything like that. So the reality is that we will raise the gates. You will be able to come and go as you please from a lunch perspective. And then also, as it relates to the sessions that we have today, of course, you guys just finished the opening session, so thanks to each and every one of you. Thank you, Gainwell. Thank you, DCH. Thank you, providers. Thank you, CMOs. Thank you, vendors, for being here. Give yourselves a big hand. So the sessions that we have today, of course, at 10:40 to 11:40, we have Autism Services and AmeriGroup, and that's in the Grand Ballroom, and then in the Cumberland Ballroom, and then, of course, we're going to break for lunch at 11:40 to 1:15, and then from 1:15 to 2:15, we have the Georgia Horizon CHBS waiver case management system update in the Cumberland Ballroom, and then we have Peach State, of course, in the Grand Ballroom. At 2:25 to 3:25, we're going to do billing basics, common denials, and how policy changes impact claims, Cumberland Ballroom, and then, of course, Care Source is going to be in the Grand Ballroom. For each and every one of you, if you don't remember anything else, teamwork is the key to what? Success. To what? Success. All right, and there's no I in team, but team stands for what? Together, everyone achieves more. Thank you. Have a great day and be great at it and enjoy all of the sessions. Thank you so much. Have a great one.